Okay, so I would like to introduce Jason Martin, who's an exercise physiologist at QUT, who we met in the Q&A session. So Jason is a clinical exercise physiologist, PhD candidate, whose research focuses on improving health outcomes across the cancer survivorship continuum. His PhD focuses on the role of exercise in managing sleep disturbance in people living with primary brain tumours and their caregivers. Very important. Jason currently works at Cancer Council Queensland, where he supports clinical casework and research aimed at integrating exercise into cancer care. Okay, and Jason's going to talk with us today about an interactive session. Oh, it is going to be an interactive session, is it? Questions, okay. Physical activity and exercise for brain tumours, understanding the why and navigating the how. Thanks very much.
Yeah, I figured I'd take away the interactive part just because we've all had lunch, so we'll just let it settle instead, all right? Yeah, you're welcome. So yeah, thank you for the kind introduction. I'm really grateful for the opportunity to be here to speak today. I will apologise in advance just in case I speak a little bit quick. This is my first time presenting at something like this, so a little bit nervous, but that's all right, we'll get through it, okay? So yeah, I'm going to talk about physical activity and exercise. So before we get into it, I thought I'd just differentiate between the two. So physical activity is any bodily movement that's produced by skeletal muscles that results in energy expenditure. And when we talk about physical activity, it's usually targeting more general outcomes. Whereas on the flip side, we've got exercise, which itself is planned, structured, and repetitive physical activity. And that's more targeted towards performance outcomes, okay? So all exercise is going to be encompassed by the term physical activity, but not all physical activity is then going to be exercise. So some examples. So within physical activity, we've got basic tasks like walking to the bus stop, gardening or mowing the lawn, taking the stairs instead of going up an elevator. Or we've got exercise, which is more or less performance related tasks. So things like running, going to the gym, going for a bike ride, or following a home exercise plan. Within exercise as well, we've got a few different types, and we can use these different types to target different outcomes as well. So resistance exercise is going to be things like strength training, which is going to work on your muscle strength. We've got aerobic exercise, which is targeted towards cardiorespiratory outcomes. And then we've got flexibility and balance as well. So now that we've talked a little bit about the difference between the two, why are they important for people who've been diagnosed with brain tumours? So in general, there's a multitude of benefits that come with performing more movement, and they can be separated into two basic groups of benefits. We've got physical health benefits and then mental health and cognitive benefits. So within physical health benefits, we have those outcomes that I mentioned before, such as cardiovascular health, increased muscle strength, and reducing the risk of things like chronic disease. And within mental health and cognitive benefits, we've reduced symptoms of anxiety and depression, improved mood and stress management, and enhanced things like sleep quality. And all of those benefits then come together and they result in an improvement in quality of life and longevity. Within cancer, in the context of cancer, we have a lot of literature that shows that we've got some really strong evidence for a number of outcomes, okay? So the strong evidence shows that exercise is beneficial for things like cancer-related fatigue, health-related quality of life, physical function, anxiety, depression, and lymphedema. And we have some moderate evidence to suggest that it's also beneficial for bone health and sleep as well. As I mentioned in the Q&A before, the evidence for exercise in brain tumours isn't as clear, but we do know that there are a multitude of beneficial outcomes as well, which align with those in general health and cancer-related outcomes as well. So these are things like cardiorespiratory fitness, muscular strength, muscle mass, and balance, as well as cognitive function and attention span. And we do see improvements in anxiety, depression, and psychological distress, and symptom severity and fatigue. Again, all of these things coming together to result in improved quality of life in those who have been diagnosed with a brain tumour. Now, it's all well and good to talk about the benefits. The hard part is actually incorporating physical activity and exercise into daily life. Okay, so how can we do that? In the context of exercise, we can split it into 3 different parts. So we can talk about prehab, we can talk about rehab, and then we can talk about long-term survival. So within prehabilitation, this is a time point that is set before or early in treatment, and the goal is to build physical reserve and improve functional capacity while optimizing mental health and coping capacity through exercise. In this time period, the goal is to potentially reduce treatment-related complications that may arise throughout the treatment process, and the focus should be working on aerobic and resistance exercise that's tailored to baseline fitness. This is also a unique time frame because it gives us an opportunity to emphasise preparing the body and mind for treatment itself, as well as provide some education and habit formation, which can be used later in the treatment process, so during rehabilitation and longer term survival. So rehabilitation is going to be during and after treatment, and the goal here is to restore or maintain function that's lost during treatment and disease. The idea is to reduce symptoms where possible and to improve quality of life, and to support return to work or daily roles if this is going to be something that's applicable. During this period, the exercise should be targeted towards deficits that arise during treatment. And this can include things like gait training, strength reconditioning, aerobic reconditioning, and cognitive or dual task training. So prehab and rehab are both very useful time points to start incorporating exercise. And in an ideal world, it's something that everybody would have access to. However, this isn't usually the case, and it's really important that I just highlight here that prehab and rehab serve different purposes, and working together would be beneficial. However, one is going to be better than none. So if you can only perform exercise at one point, it's going to be better than doing nothing. As we move into longer term survival, the emphasis shifts to more general outcomes, and to prescribe our exercise, we can use the exercise guidelines. Now, these exercise guidelines have been stipulated by 3 governing bodies for exercise and cancer in general. So we've got COSA, ESSA and ACSM, who have all put out their own specific guidelines. But as you can probably see in the table, they align with each other pretty closely. So we're aiming for about 150 minutes of moderate intensity or 75 minutes of vigorous intensity aerobic exercise per week. And resistance training and flexibility should be performed on 2 to 3 sessions per week as well. The key principles that are endorsed by these exercise guidelines include exercise being safe and effective throughout, during and after most cancer treatments, and exercise should be individualised, accounting for things like cancer type, treatment, side effects and comorbidities, and be based on an individual's baseline fitness. Exercise should ideally be prescribed and supervised by an accredited exercise professional, such as an exercise physiologist or a physiotherapist. So I just wanted to give a quick example of someone that I've worked with in the past. The name is obviously not their name. So John was a 48-year-old recreational bodybuilder prior to his diagnosis, and he was diagnosed with an anaplastic astrocytoma. His treatment included surgery, radiotherapy, and chemotherapy, and he had some significant side effects, including right-sided hemiparesis, fatigue, and balance issues. When he came to see me, the goals were to try and regain as much independent walking capacity as possible, rebuild strength and confidence, and to return to the gym, because this is something that he really enjoyed in the past. So with the idea of trying to meet our exercise guidelines, because this is something that John really wanted to work towards, we focused on getting 2 gym sessions per week, which was face-to-face with me. And then we did 2 aerobic sessions per week because he had an exercise bike at home. So the timing of the sessions was about 45 minutes per gym session, and then 30 minutes per session on the bike, which totaled that 150 minutes of exercise. What we focused on was some gait and balance training. So we focused on step drills and resisted gait, as well as some functional tasks, because this directly aligned with his goal to work on his independent walking capacity And then we did resistance training and flexibility and mobility, because these are things that he used to enjoy when he was before his diagnosis. So when we were in the gym, we shifted a lot of tin, focused on bodybuilding style where possible, using a lot of machines and free weights. Over time, we had a gradual increase in resistance load and exercise complexity as he progressed. And overall outcomes included improved gait mechanics, increased lower limb strength, and a successful return to structured gym training. He also had a really strong adherence, because this is something that he really enjoyed, and this was a part of his day-to-day life before his diagnosis as well. So, not everybody is going to be like John, and not everybody is going to want to get back into the gym. Not everyone is going to want to do structured exercise. So this is where the World Health Organization guidelines on physical activity and sedentary behavior come into play. So you'll see with this figure that we want to work towards more than 300 minutes per week of physical activity, but this isn't something that is readily attainable to everybody who is going through a cancer journey. So what can we do instead? We can focus on just limiting our sedentary time and increasing our physical activity, because something's going to be better than nothing. So some ways that we can increase our physical activity just in general are things like breaking up sitting time, moving around in a bed or chair if you're confined to them. So just doing some arm lifts, doing leg lifts, ankle rotations, etc. Breaking up the day with some movement snacks and going for short walks. Modifying your physical activity to your energy levels. So there's going to be days where you might feel like you're able to do more, so you can focus on doing more. But then there's days where you can do less. That's when you focus on resting and recovery. So doing things like active rest, things around the house like folding the washing. Dual tasking is another good way to do things. So while you're doing things like talking on the phone, getting up and going for a walk, or doing some standing activities. So tasks like brushing your teeth, making tea and coffee, or reading, you can all do while standing. So as I said, not everyone's going to be like John. And a really good example of this was another person I worked with, and her name isn't Jane, but we'll say her name's Jane. She was a female who was 62 years old. She was independent and she had no major mobility deficits, but she was diagnosed with a pituitary adenoma, which required surgery for treatment. As a result, she had symptoms of fatigue, sleep disturbance, and low energy. And when she came to see me on a chronic disease management plan, so we only had 5 sessions together, she just wanted to work on managing her fatigue and improving her sleep, understand safe activity levels, and to fit movement into her daily life without overdoing it. So with a lifestyle coaching approach, we just focus on self-management and symptom education. We encourage short activity bouts, so going for 10 to 15 minutes of walking and doing some light yoga, because this is something she was interested in, something she could find on YouTube. And then we explain the difference between energy conservation and energy restoration with physical activity. In terms of her sleep, we focused on light activity earlier in the day and avoiding inactivity and late caffeine. We worked on building a nice structured routine, getting her out, going for walks during phone calls for work, doing some gardening and doing stretching before bed, just to try and down-regulate her nervous system so she was nice and relaxed before going to bed. We really educated that movement is beneficial for fatigue and sleep, and she didn't have to focus on doing structured exercise. As soon as we started to educate that we didn't need to do that structured exercise and it was just about moving, she was a lot more relaxed with the approach and she was able to focus on everything a lot better. As a result, she had improved fatigue patterns, better sleep hygiene, and she had a consistent daily movement routine, which increased her confidence in managing her symptoms independently. So we talked a little bit about this in the Q&A session as well, just around who can help. And as endorsed by the exercise guidelines, we should be trying to work with accredited exercise professionals wherever possible. So this includes accredited exercise physiologists and physiotherapists, because they're trained to assess medical history, treatment side effects, symptoms, and safety risks. Even though we have the guidelines, it's not as simple as just whacking an exercise program in front of someone and saying this meets the exercise guidelines. there's a bunch of contextual factors that we as health professionals need to take into consideration when we prescribe exercise and physical activity interventions. So some of these things include their treatment status, what are the priorities of the patient and the practitioner, and what are the actual likes and dislikes when it comes to movement. So this diagram is a very basic overview of how we approach exercise prescription as exercise physiologists. So everything starts off with a tailored patient assessment. This is where we can find out things like medical history, what medications are being taken, what treatments have been performed. And it helps us to determine and prioritise any health issues that the participant might have. We can then identify the patient's capacity and intervention suitability by doing objective assessments, with all of this information informing our exercise prescription. When we think about our total exercise dose, there's a few things that factor into it, such as the mode of exercise, so resistance versus aerobic exercise versus flexibility versus balance, how intense we want to work, the frequency that we want to do sessions, and how long those sessions go for. Our goal is always to try and get as much progression as possible, but we constantly monitor for things like symptom impacts on the exercise, and we're always focusing on providing as much education around behaviour change as we can. Down the bottom in yellow, we've got number 5, which is just our reassessment and prescription modification. So the idea of this diagram is that it's not just the flow chart 1 through 5 and then that's it. We always constantly move back to step 1. We're constantly doing assessments and reassessments, determining new priorities and identifying patient capacity throughout the disease trajectory and what they're experiencing. We did talk about some people who might be doing exercise interventions before. I did just want to leave these ones up on the board, so if you want to take a photo of it. These are clinics who I know work with exercise oncology specialists. So Higher Health, they have plenty of locations throughout southeast Queensland. And Callum Edzer, who is the clinical exercise physiology lead, he's a good friend of mine, and they're always happy to take on people. Valere Health, located in Spring Hill, are exercise oncology specialists, and I know that they take exercise sessions through telehealth as well. So if you can't get to Spring Hill, you can still get in contact with them. And then with BodyTrack and QSMC, I've just listed the details there because there's 2 exercise oncology specialists who work within those clinics, who my colleagues have worked with in the past, and they strongly recommend them. So we've got Caitlin Clark and Deb Pickerskill. However, if none of those options are suitable for you, you can use the ESSL website to find an accredited exercise professional near you. So the QR code on the bottom will take you to this website, and what you can do here is you can actually search for an accredited exercise professional near you, using the city and postcode and how far you want to travel from that area. If you list the area of special interest as cancer, you will find someone who has a special or particular interest in exercise oncology, and they'll be best suited to help out. Some key takeaways from today. I would just focus on moving as much as you can, and when you can, work with an exercise professional. They're going to help you through your journey. Okay, mix it up and try to perform varied activities because you're going to have different benefits from different types of interventions. Don't do too much at once. I know I've said that the guidelines stipulate doing 150 minutes of exercise per week, but if you go out without any build up to that, you're probably going to hurt yourself, so try not to do that. Focus on making sure you rest and recover for sustained health, and tracking symptoms is going to be key for monitoring health indicators and making informed decisions around your exercise in future. So the interactive side of this was just going to be question time, but there were some questions answered before, so I understand if no one's got any, and I'm happy to field them later. I did just want to leave this up on the board just in case anyone has questions. This is just the assessment that I was talking about before in a little bit more detail, so that diagram that I put up, and just some of the considerations that we factor in when we prescribe exercise in exercise oncology. Thanks.
there any questions for Jason? What I'm glad to hear is that there's oncology or cancer. I'm going to bring this down. You're way too tall. Physios around, so that's great. Thanks very much. Good job. Okay, so, yep. Who's, yeah.
Jason, can you talk us through how you might tailor specific exercises to different functional impairments?
Yeah, so functional impairments is a big one. So let's just say we had someone who came in with hemiparesis or an affected side of their body. A lot of our exercise would be tailored around working the unaffected side more, because we know that we can get some crossover if we just train one side. It doesn't mean that we wouldn't target the affected side as well. We would do as much as we can with that, but we would try and maintain as much function in the unaffected side as possible. Things like sleep disturbance is a big one. So if someone came to me and they wanted to do exercise to help out with their sleep, we would actually move any sessions that were done later in the day to in the morning as well. So if we start to exercise and do higher intensity exercise in the afternoon, we disrupt the nervous system a little bit, we wake it up and you stay a bit more vigilant, and it's really hard to wind down from that. So if we do it earlier in the day, it gives your body and your nervous system time to down-regulate. Happy with that? Cool. Anyone else? Yeah.
I just wanted to ask from a paediatric point of view, my son's returning to school, but he's also receiving 3 physio sessions a week.
Yeah.
How do you manage the balance between fatigue and still, I mean, I know going to school obviously and doing all those things is rehab enough sometimes, but yeah, how does a carer manage the fatigue and knowing when to pull back from, say, the physio sessions?
You might not like the answer to this one, but with great difficulty. It's hard to manage sometimes, particularly in paediatric populations. Kids love to do things, and sometimes when you're trying to slow them down so that they're not doing as much to reduce that level of fatigue, it can be really hard. I've always found that any paediatric patients I work with, we just try and let them do as much as they want, and as long as they're happy, that's usually a good balance. But that's not going to work for everyone. Yeah, it's a really tough one, and I don't have a lot of experience with paediatrics, but I know places like Higher Health, they have practitioners who focus specifically in that space, and they have a lot more experience with how to manage that. Yeah. Lovely. Thank you, everyone.
Hello, everyone. Just the final things, because we're going to wrap it up now. I just want to thank you all for coming. I know I'm a healthcare professional, but I thoroughly enjoy these sessions, and I always learn things, and it's just great to meet other people and, hear what's going on, whether it's from a patient or carer's point of view. And we all live in different parts of Australia, and that's the one thing about Australia is it's very different depending on where you live and what you access. So again, I just want to say a big thank you for being part of this and making your Sunday spent here rather than outside or doing whatever else you do. I'm just going to introduce Christine from BTAA. She's going to do the closing remarks.
Thank you, Marina. So for those of you who don't know me, my name's Christine, and I've recently joined BTAA as their Executive Officer because I have a background in health policy and working in health nonprofits. I have a background working in cancer. But last year, about 18 months ago, I was also diagnosed with a grade 2 oligodendroglioma. Marina there is my nurse practitioner, so she knows all about my journey. But for me, part of what's been I guess the silver lining of this experience is having the opportunity to give back to this community. So I would like to extend my thanks not only to our speakers today for taking the time to talk to our patients and carers. I think it's really important for this community to get access to researchers and clinicians to talk about what's happening in this space and get that connection to research is really valuable. But I would also like to thank everyone in the room for making the time to come here today. It really has been for me humbling to meet everyone in this community, to hear everyone's stories. I've tried to meet as many of you as possible, both the clinicians and researchers, the other patients and the caregivers, because having gone through this journey myself and sharing the stories with everybody in this room has been a really valuable experience for me. Very educational. I don't know if I got more education from the speakers or from everyone else in the room. So thank you for taking the time to come together on behalf of myself, but also on behalf of BTAA. BTAA is almost entirely volunteer-run organisation. They're all people like yourselves who have been directly impacted by brain cancer and are very, very passionate about giving back to this community. So I would like to thank the members from BTAA who were involved in delivering this event today, Billy, Pam, Pat and Philip, as well as our partners at COGNO and the Brain Cancer Group. Really nice to see everyone come together to pull this day together, and I hope you have found it as valuable as I have.